Welcome. Thank you for joining us. My name is Dr. Michaeline Friedenberg, and I'm the president and CEO of the Institute of Reproductive Grief Care. I am joined by Rebecca Capuano, Education Program Facilitator for the Institute. For those of you who are new to our organization, let me start by briefly sharing our mission and the goal of this webinar series. The Institute of Reproductive Grief Care is the global expert in evidence-based, trauma-informed grief care education and training for healthcare professionals, mental health providers, and community leaders. We are at the forefront of creating and distributing impartial and impactful research to understand the way individuals process reproductive losses. This Research and Action lecture series, in honor of Pregnancy and Infant Loss Awareness Month, features in-depth discussions with the authors of some of the latest groundbreaking reproductive loss research. Thank you for joining this important conversation. I also want to thank our co-sponsors, Burnham Center for Community Engagement, Indiana University, Indianapolis, and San Diego Magazine. We are grateful for their support and for their dedication to improving maternal mental health through education, research, and positive policy change. For all those who are personally impacted by reproductive loss, please accept our condolences and be assured that you are not alone. We remember you and we stand with you. For accreditation purposes, we have nothing to disclose. With that, I'd like to turn things over to Rebecca.
Thank you, Michaeline. Well, today we are honored to feature nurse researcher Dr. Shandy Nikki Berry. Dr. Berry is an honored graduate from Washington State University. Dr. Berry's research in perinatal loss, grief, and bereavement focuses on decreasing the emotional trauma parents experience. Her research has been presented throughout the world, published in multiple peer-reviewed journals and nursing textbooks, and incorporated into nationwide perinatal palliative care curricula. Her most recent publications have focused on trauma-informed and long-term follow-up care. Dr. Berry serves on nationwide committees and task forces with leading perinatal loss organizations, including the Institute of Reproductive Grief Care and the Perinatal Loss and Infant Death Alliance. Dr. Berry, it is an honor to have you here today with us.
Thank you so much for having me.
If you don't mind, let's start, Dr. Berry, if you could share with us what initially drew you to study long-term trauma-informed support after perinatal loss.
Absolutely. And that is a great question. As I started my research, and it began with my dissertation as I was earning my PhD, I was interviewing parents who had experienced a reproductive loss, and I kept hearing the word trauma come up over and over. I was traumatized. It was traumatic. No one can go through that without being traumatized. I was in a dissociated state. And I thought to myself, if I'm hearing all of this from participants across the world over and over and over again, I cannot possibly be the only one finding this. And so I decided to look deeper into it and I dug into the literature, and sure enough, I was finding that parents and studies and research across the globe was also seeing that there is a lot of emotional trauma associated with perinatal loss. And that's what got me interested in it and why I started going into that. Because as I was digging into it, I found that studies with pretty significant sample sizes were finding that parents would experience up to 60% of parents who had experienced a reproductive loss were still experiencing post-traumatic stress 5 years after their loss experience. And I thought that is unacceptable. That is absolutely unacceptable. If this were anything else, if this were surgical site infections, if 60% of surgical sites were getting infected, the medical system would revolt and there would be so many task force focusing on this. So that's how I started down this trail.
Wow. I mean, that statistic is pretty staggering. Up to 60% can experience PTSD. I mean, you're talking about trauma. I think a lot of us don't really think about trauma as associated with perinatal loss, but wow, that's just pretty phenomenal to hear that. Well, following up on that, from your perspective, then, why is trauma following perinatal loss such an important topic for research?
Not only is it important because it's so prevalent with individuals who experience this type of loss, it's important because if you don't understand trauma and you don't respond appropriately, then you can inadvertently traumatize the individual even more. And so, if we respond poorly to this experience for parents, we're making it worse. Not deliberately, it isn't intentional, but we're still creating harm and causing harm. And it's absolutely essential to know what can we do and how can we do it well.
Mm.
Well, I'm so glad, Dr. Barry, that you've entered into this space because I think you touched on it too, right? People are called into this field and they devote their lives to it because they want to help and they want to make things better. And so, certainly, they don't want to be the source of creating additional trauma. And I know that's what's bringing people to this webinar today. So, perhaps you could share a couple trauma informed strategies that clinicians can begin integrating right away to help reduce the risk of complicated grief.
Absolutely. The first one really is recognizing that reproductive loss can be an emotional trauma and understanding what trauma does to the body. It changes the neurobiology within our very cells. And typically, an individual who is not in a traumatic response or in a state of trauma, they have their entire brain available to them to make decisions, to think forward. So, if we look at the neurophysiology of trauma specifically, the prefrontal cortex, which is the area of our brain that normally is involved in higher thinking, things like decision making, problem solving, planning, things like memory and rational thinking, that area of our brain is taken offline during a traumatic event, such as learning that a pregnancy is ending in loss. And the limbic system takes over. So bombarding individuals that let's take an example of miscarriage. Somebody comes into the emergency department with first trimester bleeding and they're suddenly told that they are miscarrying. If their brain is in that traumatic response and it's only the limbic system processing, when we as healthcare professionals say, this is the diagnosis, this is what you need to do, here are your treatment options, what do you want to do, here's your consent form, their brain is not available to process that information, never mind make these complex decisions regarding their care. If they come in for their 20-week ultrasound appointment and they're thinking, I'm going to find out if I'm going to paint my nursery pink or blue, and suddenly they hear, oh, your baby has trisomy 13 or anencephaly, and this means that they are not going to live, and here's what we need to do moving forward, that individual is not going to be able to process that. So, the first thing that people can really do is recognize trauma, what it does to the brain, and slowing down. If we slow down and have these intentional, compassionate, empathetic responses, that right there sets the stage for healing. And that right there is something that can put parents in the turmoil of a horrible experience. It can set the stage to have some positive outcomes.
Well, thank you for that, Dr. Barry. I just have to say that thank you for creating a framework for us to think about this from, right? So it makes more sense and giving us a really concrete strategy about slowing down and how that alone can have such a profound impact.
Yes, and I think honestly, one of the hard things about the healthcare system and slowing down is we are bombarded with more things than we can accomplish in a 12-hour shift or an 8-hour shift or wherever you're working. And the idea of taking extra time with somebody may seem daunting, but we have to frame it in the big picture. If we don't, we're not setting our patients up for success like we hope to. And so that time is very important. And having institutional support is
Mhm.
very, very important so that we can actually be successful in taking that time. So perhaps, and I published a manuscript proposing a framework for trauma informed care, and it talks about having a trauma informed environment. And this involves team huddles and recognizing, okay, we have identified somebody who's going to need additional care, and we're going to have a proactive response here. If it's in the clinic setting, we're not going to put them in the waiting room with multiple patients waiting who are currently pregnant and showing their pregnancy, because that's going to be traumatizing. We're not going to give the allotted 15 minutes to them. We're going to take extra time. We're really going to set the stage there. And not only does that help the individuals who's experiencing the loss, that's impactful for the staff caring for that individual as well. Because, like you said earlier, we come into this profession as a nurse. I come into a profession to help people. I don't come in to cause more damage. And so, if I know that I'm empowered to make this horrible experience the best that it could possibly be, that's going to help me as a nurse, not only in that care interaction, but moving forward to other care interactions. And that's going to decrease the vicarious trauma that the healthcare professionals experience as well.
Oh, thank you for pointing out too the benefit, right, for the providers too. And also for pointing out kind of comparing and contrasting like what is needed compared to what happens right now. Kind of before we move on from this, are there any other strategies that you would suggest that again might be different from what families are receiving right now?
Yeah, so what families are receiving right now, and I will say there has been some really, really great examples of care that I've heard from my research participants, and a lot of it is that meaningful interaction of somebody actually slowing down and taking the time to see them and hear them. So some of the other things that can be done is communication among the healthcare team, letting the next person taking over know that there is a loss and filling in, having that warm handoff saying, this is what's going on with that family. That prevents the family from needing to recount their story over and over and potentially being re traumatized as they do that.
And I think maybe you've already been touching on this, but you've connected your research to Wagner's chronic disease model. And so I'm wondering if you can explain a little bit more how that model applies to reproductive grief care.
Absolutely. When we look at something like post traumatic stress disorder or PTSD, we don't, in healthcare, PTSD in and of itself, it's not a diagnosis that's given and then ignored. It's followed up with later on. If someone receives a diagnosis of heart failure, they're not diagnosed and sent home. They have continuing care with multiple healthcare professionals of different specialties. And Wagner's model looks at chronic conditions and says, we need to support individuals in our own specialities to help them have the best healthcare outcomes that they can, because we cannot expect them to manage their health on their own. It's unrealistic to expect someone with diabetes or heart failure or kidney failure to manage their health care by themselves. And so, looking at Wagner's model, the point is not to pathologize grief. Grief is not a diagnosis, it's not an abnormality, it's a human response to a loss. Why it's important with reproductive loss is because that is such a unique subset of loss, and it's often silent and ignored and invisible. And as it's invisible to society and to the social group, the loss becomes disenfranchised. And when grief is disenfranchised, individuals are not given that permission to publicly grieve. They don't have the social support, their circle of friends and family coming around to help them and hold them up. And so they're very isolated and alone. And we see that when individuals don't have the support they need in grieving, in moving through that grief and healing in that grief, then they can develop a lot of what we call chronic or complicated grief. And complicated grief, it's associated with multiple adverse health outcomes: depression, anxiety, PTSD, eating disorders, sleeping disorders, substance misuse, suicide, cardiovascular disease, endocrine disorders, immune disorders. It goes on and on and on. There's multiple health complications associated with complicated grief. And when we look at complicated grief and reproductive loss, studies are showing that up to 75% of parents experience complicated grief, which, again, like the PTSD, it's very staggering, especially when we look at other types of grief, the loss of a partner or a spouse or a friend or an older child or a parent. If we look at non reproductive loss, complicated grief occurs in about 4% of those individuals. And so that's really important to look at this specific subset of loss and ask ourselves, why on earth is this such a significant health outcome? Why are we having all of these complications? And it really comes back to that silence that's placed upon it and these parents not getting the support they need. So if we look at reproductive grief not as a pathology, but as an experience and a health outcome that requires continuing care, Wagner's model can be helpful in that because we already have a process established in our healthcare system of providing continuing care to individuals. And so, really, the question is, why do we provide continuing care for physiological disorders, but not for individuals who've experienced a reproductive loss? Why are they falling through the cracks? Why are they not getting that continuing care that they really need?
So it kind of sounds like really that this model is a way of just trying to really increase the support. Maybe the not only dealing with physical emergency, but the emotional emergency that's going on here in this situation with a perinatal loss. Would you say that's a way of characterizing it?
Oh, absolutely. And if we don't have somewhere to start, then there's not going to be momentum moving forward. We need to have somewhere to start, and that at least gives us an example that we can mimic or utilize and apply to this experience.
I know you've been talking about the follow-up and wanting to make sure that there is that support. So how would you say that using a chronic disease framework can shift the way that we think about follow-up care for parents after loss?
I have pondered this a lot myself. And one of the questions I ask myself is why isn't that follow-up care? If why isn't it there? If someone has a baby, they get that follow-up care. They go back to the pediatrician, to the neonatologist. They have those set markers of, I have my appointment this far out and I'm being monitored for these complications. If there's not a live neonate, then that monitoring ceases. The healthcare system doesn't think, oh, wait a second, we need to continue that, because there's this misconception that once someone leaves that hospital or that clinic, their experience is over. But
Mm.
that is not the case with reproductive loss. That experience doesn't stop. I had a father tell me that it's not like a book. It doesn't have a beginning and an ending that you can close and put on the shelf and never read again. That a book that stays open, those pages are continuing to be written. That story is ongoing. And so we need to change our mindset and recognize that that story doesn't end with discharge. That story continues, and those families continue to need that follow up care.
I just have
Right.
to say, I really appreciate you sharing that as somebody who has personally experienced reproductive loss. I mean, I just so connect with you saying that pain can continue on long after the end of the third trimester. So I just appreciate that you are doing this work and this recognition for the importance of that follow up care afterward.
Thank you. I appreciate that.
Yeah, and I think Rebecca, I so agree with that. And of course, I'm really sorry that you've personally experienced this. And it is troubling to me that after a loss, their postpartum, but as you said, Dr. Berry, not really recognized or treated that way. So I'm wondering, sometimes we've been hearing the term fourth trimester thrown around. I'm wondering if this has something to do with it. Could you tell us exactly what that means?
Absolutely. So the fourth trimester is that period from immediate postpartum or birth up to 12 weeks after. And in that time period, it's the standard of care. If there is a live birth, there is going to be follow-up appointments and there's going to be health assessments and mental health assessments. And just because there's not a live neonate doesn't mean that the body is not still going through those physiological changes. That doesn't mean that the parents aren't going to be having any needs or requiring any type of support. For example, if someone experiences a reproductive loss, the body physiologically does not know there's not a baby there. And so after 16 weeks, I mean, the body is physically producing milk. And so the individual can then begin lactating. And when there's not a baby to feed, that can be incredibly traumatic, very emotional when the milk comes in. And without that follow-up care, even without a lactation consult before the individual leaves, that's a surprise. Like no one expects that to happen. Every parent that I've talked to, they were shocked when that occurred and they didn't know what to do. Or if bleeding persists, that's a constant reminder of that baby that they don't have anymore. And so just sending somebody home who's still having these immediate physiological reactions to having gone through a pregnancy, they still need even the physical support with that. As I have talked to some different healthcare professionals, and this I think really plays into that silence and that not quite understanding what individuals are experiencing as they go through this loss, I've heard often we deliberately don't do a lactation consult because we don't want to traumatize them. And while I can see that perspective, what the research is telling us and what the families are telling us is that I need that lactation consultation. I need to know that my milk is going to come in. I need to know how to manage the discomfort with that, the emotional response to that. And so, even something simple as anyone who is 16 weeks or later at the time of loss, just having that lactation consult and saying, this is going to happen. You can expect it within a few days. Here's a number you can call if you have questions. Just having that written information. Even sending individuals home with pads, with sanitary pads, can be really helpful. I had one woman say that she ran out of pads and she was unable to go buy them herself because it was too emotionally traumatic for her to buy those pads when that blood meant her baby wasn't there. And she was too embarrassed to ask anybody. And so she said she didn't know what to do. She just sat on the toilet and bled and she didn't know who to talk to. And so as healthcare professionals, as nurses, as providers, as therapists and social workers, we can check in on these things and say, this is going to happen. This is what you can expect. Send them home. I mean, nurses are great at sending patients home with extra supplies. So, anyone in the audience who's in that obstetric unit, just like load them up with some extra sanitary pads and say, here's the number you can call, and we will make sure that you have what you need. Those are some of the things that can be really impactful, especially in that first week after loss when everything is so new and raw.
Right. That makes a lot of sense. And it's those small but very powerful and profound things that we can do that sometimes, right, we're not thinking about that right now. I'm wondering, I just want to dive in just a little bit more on that. So you mentioned lactation, you talked about preparation. I wonder maybe because this is a topic that is just almost never talked about, maybe, I know that there's some options, right? If they choose suppression or if they choose to donate. I don't know if you'd want to talk a little bit more about that.
There are options, and there are milk banks that accept breast milk donation, and some individuals find that a very meaningful experience to be able to donate their breast milk. In the reproductive loss experience, parents are looking for meaning. They're asking, why did this happen to me? Why me? And it really, there's an identity crisis and they're in an existential crisis. And as they are seeking meaning, if they can find some way to give back, then that can really help with post traumatic growth. That can help with that healing process. That can give meaning to their loss and their experience, knowing that their breast milk is not going to waste, but it's going to help some other family. And not everyone chooses donation, but offering that choice is really, really powerful. Some of the principles of trauma informed care is restoring that control, offering choice, giving autonomy. Because when someone goes through a traumatic experience, when they experience a reproductive loss, their choice is taken away, their control is taken away. And so, if we can restore that to them, then that can empower them to begin healing as they start to process their grief and their experience.
Right. That makes so much sense. I like that you point out that it's going to be unique for every individual. I also think about when you're saying that options, and you had spoken earlier about when we go into that trauma is occurring, and it's almost like, right, you're shutting down, and that's why you're advocating slowing down. It sounds like providing concrete options might also help to kind of order some of the thinking and the reaction at the time.
Absolutely. And again, like you said, each person is unique and they respond uniquely. So some families, they might not be able to make decisions right away. Some may be able to make decisions. Some may have absolutely, the majority are going to have absolutely no idea what they need in that moment. But as healthcare professionals, we can come along beside them and sit next to them and say, families who have gone through similar experiences, sometimes they find this helpful, or this is an option for you if you decide to choose that. And then letting individuals know there's not a right or wrong answer, or there's not a right or wrong response in this. Just letting them know that they can choose and that you will do your best to give them, as many choices as you can in their experience.
Right. Yeah, thank you. I'd like to spend just a little bit more time here, just since we're in the practical application part. I know people are always really eager, right, to hear about what they can do. And so there's two other things that come to mind, and maybe you want to comment on more, Dr. Barry. But I think of the social stigma. And so, is there anything practical that we can do to help with that, or to prepare a patient? And then I'm also thinking of that, like that first follow-up visit. So after your loss, I'm just wondering if there's any tips that you could provide for us in either of those areas.
Absolutely. And if I leave off the second question, please rein me in and bring me back to it. But with the stigma specifically, a lot of times, if you don't know what to do, if I don't know what to do, I tend to do nothing. And so, in the healthcare system, if we find ourselves not knowing how to respond to a loss, or how to talk about a loss, or talk with parents who have experienced that loss, not saying anything is starting that disenfranchisement of their experience. It's beginning the silence along their journey towards healing, and it may complicate the healing. And bringing it up, acknowledging the loss is so profound. So that's the first step that individuals can do to break that stigma, is by acknowledging that loss and that it's there. So saying, I see you in your grief. I want to be here with you, and I'm happy to sit in silence. You don't even have to say anything. I'm happy to listen to what you have to say. Um, Individuals who have later term pregnancy loss, or who have had a congenital anomaly, they have a little bit of time to bond with their baby, and oftentimes they will be very intentional about memories they make, and they want to talk about their baby, and that's their son or their daughter. And so listening to some of the things that they have intentionally done can be very powerful in that, and just facilitating those conversations. So begin by acknowledging that they are experiencing this loss. Another thing is setting them up for what they might experience after they leave the hospital, because the world is not prepared to have a conversation about reproductive loss or to know how to respond because it's so silenced. So, just letting parents know when you go home and you talk about this with other people, they're probably going to say some things that are hurtful. They don't intend to be hurtful, but people don't know how to respond. So, I just want you to know that that's a possibility. Some of the things that and you can give them examples of what other parents have said. Like, a lot of times people want to put a silver lining on it. So they say, at least you can try again. At least it was an early loss. At least you didn't know the baby's personality. Those are some of the things that they might hear. So just warning them that that's going to happen can let them prepare for it, and they won't be blindsided by it when someone they really trust and love says something hurtful and impactful like that.
Mhm. That's really great. That is really helpful. And you said I could remind you about the second part.
Yes.
No, I just was thinking about you talking about leaving and then they go back to family. But at some point they do need to go back and get a follow-up care, medical care. And I'm just wondering when you're thinking of those practical interventions for, providing support, if there's anything you want to speak into to that bridge that's going to take them into follow-up care after the immediate loss.
Absolutely. And in those immediate times, what my research has been showing me is that about 1 to 2 weeks after the loss, everything is so raw and numb and just crazy that it's the physical symptoms that's really the priority for families. The bleeding, the lactation, cramping, pain, as the body just kind of returns to not being pregnant. And so intentionally asking about those type of things, having a phone call, maybe 5 days in or something, saying, it's been 5 days since you left, and we really want to check in and see how you're doing. Can I ask you a few questions, or may I ask you some questions? And then just assessing, are you experiencing bleeding? Has your milk come in? Um, are you experiencing pain? Those type of things. As the time progresses and the body kind of goes back to its normal biorhythms, then the assessments can turn towards coping, anxiety, depression, grief, and just asking questions of how are you doing? And genuinely asking, not the polite, oh, hey, how are you doing? But how are you doing? And giving them permission to talk about what they're experiencing. Because another thing families are finding is that everyone wants them to return to normal. And there's this big push to act like none of this happened. Go back to work, fulfill your roles and responsibilities as parent, as spouse, as employee, as friend, as whatever their roles are. And so having the healthcare professional step in and say, hey, how's that going? How are you doing? And listening for things, asking how are they sleeping? How's their eating? Are they eating? Because so many families are saying, I just have no interest in food right now. I can't eat, or I can't stop eating, and I've already gained 10 pounds or whatever it might be. Those are intentional assessments that we as healthcare professionals are trained to do. And so implementing them with intentionality and with empathy is really important as those weeks progress after that loss.
Dr. Berry, as you're referencing those things related to bridging that gap to when people are leaving, one of the things that I was thinking about is, are there some specific things that you would suggest that providers could do to really help patients assess the support systems that they have when they leave?
There are some ways. And this might be something to do a week or two after, or maybe even a month after they experience that loss, because in those immediate times, everything is so turbulent. They might not really understand what they need and from who. But having them sit down and say, okay, a lot of people have, difficulty with this. Who's a friend that whenever you have something on your mind, you call them up, whatever time of day it is, you grab that cup of coffee, you have that phone conversation, they're there. Let's write down their name. And when you are just feeling like you need to talk to somebody, you call them. Or who's that person that is just always trying to feed somebody? That's how they show you they love you. When you need someone to cook you dinner, you call them and they are going to bring over that casserole or that macaroni. And just having a plan so that when they find themselves starting to be hungry again, but they don't have the energy to cook, they can call somebody and they can get that support that they need.
All of this is so rich, and I know that there are some questions that people are starting to ask, and they can put them in the Q&A box. But I'm wondering, kind of to wrap this part all together, Dr. Berry, if you could share an example of how intentional long-term support makes a difference for families healing.
Absolutely. I was thrilled to have a patient or a participant in my study on follow-up care actually have a good experience. And some of the things in her good experience were she had an empathetic care team. It was a designated care team, and they genuinely showed her that they cared and they felt her loss and they were there with her. She had a lactation consultant before she was discharged from the hospital. The doula that she had actually was a grief doula, had been also been trained as a grief doula, and so was able to really be with her in her grief and guide her through her grief. As she went home, she had a very supportive family who was providing meals. She had a partner who really understood. She had a therapist who was intentional about following up with those therapy appointments. And she had a nurse who would call her every 3 weeks to check in and see how she was doing. And having that team come up around her and support her, it gave her something positive to anchor to. Because in trauma, there's what we call the trauma vortex. And individuals, as they are triggered and they have these triggers, they're brought back into that traumatic experience, and their brain is telling them that they are not safe. They are there in that moment of trauma. And if someone doesn't have a positive to anchor to, then they get stuck in that trauma vortex. They don't have something to ground themselves and remind themselves that they are safe. They are not in that moment. They are capable of moving on and of healing and getting out of that moment. So having that intentional response, it really gives someone that positive anchor, whether it was a nurse that just sat and cried with them, whether it was a provider that held their hand, whether it was a social worker that listened to their story, or a chaplain that was there with them for hours as they unpacked their grief. Having that positive anchor really gave this individual the power that she needed for post-traumatic growth, and she was able to go on and heal even though she had the worst imaginable experience of her life.
How incredibly fortunate that she had that experience, because unfortunately, we know that so many don't have that experience. And I know with my own situation, I had very different experiences with two different providers in the same hospital. So it kind of speaks to that, the importance, as you were talking about, of having a framework by which we can approach this in a systematic way so that we can be more intentional about doing things across the board that are going to be supportive and helpful for these patients. Well, my goodness, this has really just been an incredibly enlightening conversation. So thank you so much. Well, now we would like to move to a little bit of a Q&A time, and we want to open it up for you all as participants to ask some questions. So if you have not done so already, please take a moment now, go ahead and put those questions into the Q&A box, and we are going to try to get to as many of those as we can. So as you all are working on doing that and putting in your questions, Dr. Berry, if you don't mind, I just had a question I'd like to start with here. And that's really, why do you think that follow-up care after perinatal loss has just not become standard practice in most healthcare systems?
Well, I get all sorts of worked up about this, and I am happy to answer this question. It's because there is no importance, no structural systemic importance put on reproductive loss. Because it's invisible, because of our current medical model, we don't value individuals who are experiencing this loss. And without that value, we think about the I say we because I am a part of the healthcare system, but value is placed on what makes money. And
Mm,
so we need to stop looking at it through a financial lens and look at it through a human lens. But
mm,
even if we do look at it through a financial lens, if we look at the impact of complicated grief and post traumatic stress disorder, it's expensive. It costs billions of dollars a year of the healthcare system. Depression alone costs over 200 billion dollars a year treating that. So if we're calloused and look at it through a financial lens, we can look at it by how much money can we save by being intentional when that traumatic experience occurs and responding accordingly, responding compassionately, intentionally with follow-up care to prevent those complications from occurring later on, to prevent the cardiovascular disease, the endocrine disorders, the immune disorders. So really, the silence is a huge piece of it, and that lack of value. So, as healthcare professionals, we need to speak up and say this is unacceptable. It's really unacceptable that we are not providing this level of care that families need because it has long lasting implications on health and wellness, not just of the individual, but of families, communities, and healthcare systems, as well as the healthcare professionals that are in that system. I'll stop there. I could talk the rest of the time, but
No.
in case there's more questions.
No, but Dr. Berry, thank you for that. And thank you for your passion and your energy. And I think also like we can all be part of that solution. And I think today is a little part of that, right? And then we can continue that standard or carrying that standard, right? Moving forward. There's a couple questions that are coming in comments. And so we have it says, thank you for validating that loss is a trauma. And then they were asking for maybe you could talk a little bit more about this, some other examples of how this is a form of emotional trauma. Not only the
Absolutely.
loss itself, but maybe right, what people are doing or failing to do right now.
Yes. So, with a traumatic experience, someone may or may not develop PTSD. When they develop PTSD, it's because whatever is occurring is overwhelming their capacity to cope. So, if we come beside families and we support them in that, we are expanding their capacity to cope. We are not only seeing them in their experience, but we're giving them the tools and the resources that they need to heal and maybe even to avoid developing post traumatic stress.
You know,
I hope that answers the question.
well, I actually have something to follow up to that. It does. Thank you. Another question that kind of relates to that that's on here is you're mentioning the post traumatic growth, and you just talked here about them coping. Could you talk a little bit more, maybe about that post traumatic growth and what you see, maybe particularly that providers can do that can help support that process of somebody getting to the place of post traumatic growth?
Yeah, humans have an amazing capacity to be resilient. And humans can overcome absolutely anything, but we cannot overcome things by ourselves and in isolation. And so the first step in helping someone towards post-traumatic growth is being with them in their experience, seeing them, acknowledging them, telling them that yes, this is horrible. I wish this wasn't happening. Anyone in your situation would be devastated or numb or, whatever it is that they're experiencing. Really validate what they're experiencing and let them know it's normal. Because when families experience this intense grief and then no one acknowledges it or talks about it or notices it, they start to think, what's wrong with me? Why am I feeling this? I shouldn't be feeling this. And that begins to fester. And then they are a problem. They are a pathology, when really all they are is a human experiencing grief. So we can really be very powerful in facilitating that post traumatic growth simply by acknowledging what it is that they're experiencing and normalizing their experience.
Mm.
Yeah, thank you for sharing that, Dr. Berry. We have both a comment and then a question. And so one of our participants shares that her daughter's birthing experience resulted in tragic fetal demise in 2016. And she said, with none, in all caps, of the postpartum support discussed here. And she says, I'm so grateful that reproductive loss and perinatal maternal mental health is now on the radar of healthcare providers. So I just first want to say, like, oh my goodness, like what you just described, that your daughter went through when you losing a grandchild. So thank you for sharing that. And then thank you for your affirming comments. And then she does go on to ask you, Dr. Berry, if you can discuss some more about the findings in your own research.
Yeah, and I really do want to reiterate, I wish that did not happen to your daughter. Um, and I'm sorry it was handled so poorly. So, in my research, really what I'm finding is that that's unfortunately a very common thing that occurs. And families can be really influential in helping as well. So, as far as supporting your daughter, even just letting her know that you still see her and you remember that loss. Milestones and anniversaries are something that are in the forefront of parents' mind often. Mother's Day, Father's Day, birthdays, holidays. Those are reminders that their child isn't there, and people think my child should be here learning to ride a bicycle, or we should be decorating the Christmas tree, or whatever other rituals, cultural rituals that there are. And so even just simply saying something that, like, I remember your child, like, I wish they were here too, I also miss them, and opening up that conversation, it can be really, really powerful. It makes me think of one of the participants that I interviewed in my dissertation study. I interviewed him 12 years after his daughter had died of anencephaly, and in talking to him a year later, I spoke with his wife, and she told me, she's like, I don't know what you said to him, but he's been a different man since his interview with you. And so the only thing that happened, I just listened. I sat there and I listened to him tell me about his daughter and his experience. And I said probably 3 words the whole 90 minutes that I was talking with him. And so simply listening to what has happened but it was life changing for him, and it's life changing for others as well. So that's something that we can do. I mean, for those that have experienced loss in our own lives, we can walk away from this and say, you know what, it's perinatal loss awareness month, and I remember your child, I remember your miscarriage, I remember your stillbirth, and I just want you to know that I've been thinking about you. If you want to go for coffee, I'd be happy to take you to coffee and we can talk about it. Just extending that invitation.
It's just so powerful. The silence can be feel so dismissive to those who've had a loss. And just knowing that somebody is willing to hear and to ask about your situation and to hear your story is so incredibly powerful. Broadening out from kind of along that line, broadening out from providers to thinking about maybe friends and family. A question here is about recognizing that everybody does have individual and different needs, but what is one particular thing that family, or maybe even a couple, that family and friends can do to support a woman experiencing loss to be sure that they don't re-traumatize that person?
Being transparent and honest is one of the best things you can do, because you don't want to disenfranchise by not saying anything. And a lot of times, that fear, that very real fear of making the situation worse, it keeps us silent. So, one thing you can say is, you know what? I don't know what to say. I don't know how to help you, but I want you to know that I care about you and I know that this was a big part of your life. So if you think of something that I can do, please let me know. I am all ears. And if I say anything that is offensive or hurtful, please know I don't mean to. And please let me know what that was so that I don't say it again. So really, I mean, that transparency, it goes such a long ways.
Mm. Yeah, thank you, Dr. Berry, for that. I have been hearing so many times throughout what you've shared with us about people's desire to be, as you've said, seen. And so we play a very significant role. It means that we are the person then, right, who are seeing them and for them to know that they're seen. So we're coming right now to the end of our time. So I have two things if I can. One of them is just going back to your research. So, you had talked about statistics considering with complicated grief resulting from reproductive loss. And I know you've done some very specific research on this, and they're asking if you could point to the study that confirms that correlation.
The 60% with
Uh,
grief.
yeah, and also, yes, I think you mentioned the 60%. I think you've also talked about complicated grief as well.
Yeah, so the 60%, it comes from Westby was the primary author that had that study. I want to say it was 2020, but I can't remember off the top of my head. And I believe there was 200 and some individuals that took part in that study. One really, really sentinel study that has come out was actually this year that was showing that reproductive loss is a health disparity and a significant predictor for maternal complications. Um, and I don't know if there's a way we can retrospectively share this with the audience because I don't have it on me. But they were finding this. It was such a great study. They controlled for things like prenatal diagnoses and mental health conditions, and we're finding that women who have reproductive loss have worse outcomes than those who have a live birth. And so, really, we can't ignore the literature anymore. We can't ignore the evidence anymore. It's all there. So, now the question is, what do we do about it? We need to know. We know it's a problem. So now we need to focus our research efforts on how do we do this and how do we do it well so that we can really facilitate that post-traumatic growth.
We're definitely hearing your call to action again. And I know you've done scoping reviews as well, which is why you're such an expert at looking at what the literature and the body of research is. So we do a follow-up email, so we can probably drop a couple of those studies in there, Dr. Barry. Just get them to us, and we'll make sure that that goes out to all of our participants. And so certainly they're interested in your past studies, but we're also interested, let's have this be our final question. What's on the horizon for the research that you will be doing?
Yeah, great question. So I'm looking to start some policy change and some systemic changes. I have just submitted a manuscript looking at why isn't there follow-up care, and I really critically appraise our current health system to investigate why isn't this being done. To follow up with that, I'm going to continue on my follow-up care research. So there's an article coming out soon within the next couple months. It's in press on what families need immediately after and throughout the year following their loss experience. And from there, I'm going to continue to build on what kind of resources can we intentionally incorporate in order to facilitate that post-traumatic growth.
Well, thank you for all of that. I know that I'm really excited to see the results of those studies and then to share that with others. We have covered so much. Dr. Berry, you've given us not just a lot to think about, but I think you've given us a lot to do, both personally for those around us, professionally for those that we serve. But I think you also did a call to action even beyond that, right? Advocating within our communities. So thank you so much for that. You're truly helping to advance a standard of care in reproductive grief.
Yes, and thank you so much for having me. And to the audience that participated today, thank you so much for being here. And I am excited to see what you all do because it's not a one person thing. It's going to take all of us standing together.
Mm. I want to echo that. I want to thank all of you for joining us today. Your commitment to enhance compassionate care practices is so encouraging. And if you've enjoyed this event and you'd like to know more, I encourage you to register to join us next week as Dr. Clay Brigance shares his research and practical tips about how to care for couples coping with infertility. Additionally, for those who are interested in learning more about the Institute's Emergency Department program, we're offering a complimentary consultation. Information about how to sign up for that, you can see that on the slide, but also you'll get that in your post-webinar email. And thanks again to our sponsors, Burnham Center for Community Engagement, Indiana University, Indianapolis, and San Diego Magazine. And then finally, and I think this is also where we can do this again, right? Let others know that they are seen and they're heard. So during Pregnancy and Infant Loss Awareness Month, let's all take a moment to reach out to someone who's been personally impacted with words of acknowledgement and support. And thank you, Rebecca, for co-hosting with me.
It was great to be here, Michaeline, and we hope to see all of you next week.